The first question we've been getting a lot of is, how do I know whether I need to schedule a person in person for an in-person visit, or if I need to send them the red cap so that they can be a telemedicine appointment? And the first thing, there's a couple different formats we did to make it easier for you to see, but any annual exam that is 40 years or older is an automatic in person with the nurse practitioner. So that'll probably be the easiest one of the easiest ones to determine. Automatically 40 and up in person. Now, anybody who is less than 40 at 39 or less, if they say they need an annual, then we need to determine if a PAP is due. And if a PAP is not due, then they may be able to have a telemedicine. But if the PAP is due, we do want them to come in person with the nurse practitioner. And we're going to go over the workflow for how to determine if a PAP is due. We don't want our clerical staff having to try to figure out if they need to come in or not. We've got a process worked out where they can communicate with the clinical staff in the back to determine this. And then if a patient comes in or calls with a problem, if they're having vaginal bleeding or abdominal pain, testicular pain, anything that's more of an urgent nature, then if the nurse practitioner is in that building seeing patients and you can get them an appointment with the nurse practitioner the same day, then they can come on in with that nurse practitioner. However, if the nurse practitioner is not going to be there for several days, then we ask the nurse to triage that patient because they may need to go to an urgent care, an OBGYN, or an ER for immediate assessment. If the patient says, I just want to change from, pills to the patch or pills to the ring or something like that, they just want a method change, then it's the patient's choice if they want to come in person or if they want a telemedicine appointment. Procedures, of course, that's going to be one of those easy ones where it's going to be always in person with the nurse practitioner. And then as we open back up where we're going to have the reproductive health nurse schedules and the nursing schedules with our nursing staff, you will be able to put the asymptomatic STDs in with the RNs, symptomatic, contact to syphilis, treatment onlys, all of those nursing visits back on their schedule. Here's the same information, just in a little different view. And it depends on kind of how you like to view it. This one is going straight down. So what are those visits that are going to be in person? And that's for any annuals that are 40 or greater years old. Any urgent problems, if they're having pain and you can see them or the nurse practitioner can see them on the same day, you can put them in an in-person with the nurse practitioner on the same day. And then, of course, the LARC insertion or removals for IUDs or the implant. For telehealth, there's two types of visits. The first one is an annual that's 39 or less years old. And if you go down to the subscript number 2, clerical is to check with the nurse to see if PAP or other testing is due. And the nurse will let the clerk know if an in-person or a telemedicine is appropriate after she does a quick chart review. And then the patient can also have a telehealth if they're a method change going from pills to depot to patch or ring. Now there was some confusion as to an STD clinician and a non-STD RN. So those non-STD clinicians are those who are maybe newer and have not gone or completed the STD nurse course. As long as they have Appendix B of the STD standing order signed, they can still give medicines for positive lab. They can also do reproductive health lab only draws and give depot or do pill pickups. It is up to the STD clinician, however, to do those STD, the ones that are symptomatic, the DIS referrals, and contact to syphilis. So maybe one of these grids might help you to differentiate a little bit with the different types of visits. So what are hybrid schedules? We've been talking about, hybrid schedules are coming. Well, the nurse practitioners have been doing telemedicine now for 9-10 months. And now we are going back to where each nurse practitioner is going to have some time still in all of her clinics and also some time with doing telemedicine. So those hybrid schedules are being developed by your regional leadership, and they're going to be put into the system so that at a glance, the clerical staff can know if they're doing telemedicine or if they're doing it in person that day, and also what location they are at. So that's what it is moving to a schedule of in-person and telemedicine visits together. When the APRN is doing telemedicine visits, they are covering the entire state. So any clinic in any location that needs to have a patient seen that day can book with that nurse practitioner for telemedicine. It's not just their region that has to book with them. There is going to be an outreach plan to help patients in the communities know that they can access both in-person appointments with our nurse practitioners as well as telemedicine. And the final thing is it's going to help clerical know to be able to see the APRN schedule. And like I said, I'll show you in a demo how to see if it's in person or if it is telemedicine at a glance. So another huge question was, who is responsible for what? And I want to, so this presentation will be sent out by Deborah and Precious as soon as it is over. But essentially we call it the originating health unit, which is the one that gets the call from the patient and puts them a telemedicine appointment on the nurse practitioner schedule, whether it's the nurse practitioner that's in their region or whether it's a nurse practitioner from another region. That's the originating health unit. The destination health unit is that health unit that has the nurse practitioner working telemedicine in it that day. Okay, so the originating health unit is going to take the call from the patient. They're going to send out the red cap. They're going to pull the completed red cap. Very important, don't just pull off what they say. You've also got to update the information in Entergy as well. You're going to save the red cap in the patient record under images so that we have that copy of the consent forms that are signed. You're going to run their eligibility to verify eligibility. And then you're going to set up a Zoom appointment for the destination NP. So if region 1 is making an appointment for one of their patients in region 9, they're actually going to set up a Zoom appointment not for Shelley, but for Andrea, the nurse practitioner that's going to be seeing the patient. And we have in the telemedicine instructions, there is a grid, and we can also send that out as well with all of the nurse practitioners' Zoom accounts and passwords so that they can get in and set them up an appointment. Then you're going to send out an email with the correct Zoom link, time and date to the patient. After that, the originating health unit is done. Then the destination, the one where Andrea is sitting on the day of service, the destination health unit clerical is going to pick up. They're going to verify the consents are uploaded into the images. They're going to verify that insurance eligibility was run and it's correct. They're going to put in the date of the appointment and yes for consents obtained. Just in case, you go down here to privacy and you hit new. Yes, and then today's date and save. And so that is telling us that, yes, we did consent and we have consent to run the prescription history. So make sure the destination health unit puts that in on the day of service. Okay, so then they're going to check all the telehealth patients in on the flow tracking, which is just a click of a button, in. They're going to, at the end of the day, the nurse practitioner is going to need to communicate back with the front desk who no-showed for their appointment, because there's really no way for the clerks to know who no-showed for a telehealth appointment unless you let them know. So nurse practitioners let the clerks know so that they can then undo the last event, which undoes the check-in, and then they're going to mark them as a no-show. When they mark them as a no-show, that takes that encounter that's automatically created whenever you register them in, it takes that out and marks it as a no-show. Then they're going to go to their pending charges, and they're going to go ahead and do their charges for Andrea and everything that she did for the patient. And that goes under the Destination Health Unit's journal for that day. For the patient who brings in their own depot, do we charge a nurse visit? For the depot, we are doing a nurse visit. Yes, the 99211. And we charge for the medicine. But if they're bringing their own depot in, like the pharmacy has already sent it to their house and they just don't want to self-administer, you don't charge for the medicine because the medicine has already been charged by the pharmacy. You would just charge the 99211, and then you would document the administration of that medicine by going to administer meds and documenting the lot number and expiration. A patient went to OCP's due to not wanting to self-administer depot, but wants to come into clinic for depot, and it's not due for an annual. So yet would be either a visit for an in-person nurse or an in-person STD nurse, one of those two, so that she can do the contraceptive revisit. The updating of the registration and updating of the demographic data is typically done by the clerical staff. So I really don't. Precious, do you want to say anything else about the last question in there?
I did not hear Tammy say the nurses can do that.
No.
That was just what she was referencing was how the clerical staff should move forward and the delineation between the originating PHU and the destination PHU. That is on both sides a clerical responsibility before it ever gets to the clinical side.
Right. That's very good. Yeah. We've just been noticing that sometimes the information in REDCap is not matching the information that's in Entergy, and we need to make sure that if they do change their information and put it on REDCap, that it is updated in Entergy. And just help me get the word out that essentially REDCap is taking the place of that face-to-face registration component. And so instead of you asking the 100 questions that you would ask them in, face to face, you have asked them in a document and they have answered. So it's just looking at their answers that they've put down and updating it in Entergy. Now we're going to go on to scheduling from the wait list. So the wait list has been used very frequently since we did not have a way to book an in-person appointment. We've used that wait list to put everybody like on a virtual hold until we could get those appropriate templates relined up with the nurse practitioners and know when the nurse practitioners are going to be in the clinic in person, and also not only when, but where they're going to be located. So now, if you will communicate with your regional leadership team to find out if they have already linked the hybrid schedules to their your nurse practitioners, then you can go ahead and start pulling patients off of the wait list and scheduling them for in-person appointments. And I'm going to show you how to do that in just a minute. You need to match the appointment time, the preferred day and time that they asked for, if they asked for anything, location and provider with an open appointment slot. So I've written right here how to do it, but I want to go into Entergy. I'm going to have to pause it again because we, again, are in the live system. Okay, so going back just real quick, this is some more documentation of how to schedule that patient, make them the selected patient, and search for the available slot that coincides with the type of appointment, the location, and the provider, so that you don't have to manually search each day looking for an appointment. You can make the system search for it instead. Okay, so now it's time to relax a little bit. We're going to do a case study. So be ready to answer on your keyboards and know that all of these case studies and your answers are all anonymous. So I'm not going to be able to say who said the correct answer and who didn't. If you don't know, just guess and then we'll talk about it. So the first case study is a 32-year-old female comes into the clinic and says it's time for her annual exam and refill on birth control pills. She denies any problems. Let me just tell you that there is nothing in reproductive health that is a life or death situation. So if you do you go ahead and schedule an in-person appointment, okay, especially if that's what the patient wants, right? But we do need to ask the patient and offer telemedicine services. So the actual answer below is correct, that we do offer telemedicine appointments. Is this something you may be interested in? And then let her tell us, well, is it something that she's interested in or not? So that's correct. And if the patient says, yes, I'm interested in telemedicine, what do you say next? The correct answer is great. To make sure we meet all of your needs, let me check with the nurse to see if it's time for your PAP or any other exams. May I check with the clinical team and call you back? As soon as this is done, then you will, if she says, yeah, that's great, call me back at whatever number, then you're going to take down that number, and that's when you will task the clinical team so that they can look up the patient's chart and see if they're a candidate for telemedicine. If you will remember, back when we first launched the telemedicine, it was the clinical team that was going through all of these patients that were on the schedule to determine, what kind of appointment that they needed, right? Well, this is the same thing. It's just moving forward to telemedicine 2.0 in a way is, when the patient calls and we're able to offer either or, and then making sure that when we do offer it, that they didn't need something in person. And we don't want the clerical staff to have to get in and find out when the last PAP was and all that, because we're not just looking for PAP. We're also looking for abnormal labs, any kind of any type of exam that we might need to do. So it's not just looking at when the last PAP was. Okay. So that brings me to the next item, is to show and remind everybody how to task. At the very top on the base Entergy, you will find work tasks. So you can click there, and then in order to send a task to your nurse, you hit the plus sign with a little pop-up box that you'll be able to say, to user, it's not going to the patient. This would be sending it to the portal. This is going to a user. You're going to bring it down and say what type of appointment it was. And you can use like a phone call, you can use inter-office note. I would think inter-office note for me, but it's up to y'all, whatever you use. And then as far as the task, this is where you say, who do you want it to go to? I'm going to send this to Laura Austin. Hit OK. And then if you go down to this quick text, I've already put in a quick text here. Interested in telemedicine appointment? Can you verify no PAP exam needed? Again, to get with that, you just click this quick text and you'll find that already typed out for you. put it as high priority so we can hurry up and look at the record and get back with the patient to go ahead and schedule a appointment. Now, for the nurse to know which appointment, which patient you're talking about, we have to link this message to that. Just click right there with that box, select the patient, and then after it's ready, you just hit send, and that goes to Laura. Okay, then on Laura's side, this is what she gets. She gets an intra-office note. Are you interested? This patient's interested in telemedicine appointment. Can you verify? And then she will go into that patient's chart. She'll look it up. And if they can, then she's going to reply and say, then this is where the nurse or your clinical team will reply and say, okay, for telemedicine appointment. And then you know, okay, you can call that patient back, and then you'll start your workflow for the red cap and getting all the consent signed and all that. So now, here under your task on the base energy side, that's where you will get this back. Okay, so any questions? That's how you work a task with this right here. And then you should know of a nurse that you send it to the back, and then they research, and then they send it back to you. And Laura put in the chat, she said a tip sheet for scheduling from the wait list is available in Moodle clerical module under tip sheets. So that's also good to know. All right, any other questions? Let's go on to case study 2. A 4-year-old male calls for an appointment needing to be tested. You know, they never say what they need to be tested for, but you can pretty much guess if he's calling this, he needs to be tested for STIs. He denies symptoms. So here are the results. So what appointment would you make? So a 24-year-old for STD testing, and he denies symptoms. So the first option, we know it's going to be an in-person appointment, right? Because he's going to need some testing. We know it's going to be with an STD nurse, but the question is it on any day or on the next available RH day? And the true answer is it is this one, on the next available RH day, because he's asymptomatic. So we're going to put him in with an STD nurse on the next available day. The question changes, though, whenever I asked if he was symptomatic, how would that change? And then, yes, we would definitely put him in with the STD nurse on the same day, because then he meets the emergent criteria. And as a reminder, the emergent criteria, make sure you can see this. Can you see it? This is the standard or SOP for same-day evaluation criteria for the clinics. And if anybody comes in with any of these symptoms or scenarios, they can be seen by the STD nurse, even if she only has a nurse template. On the nurse template, there is a visit type called RH Emergent, and any of these 3 scenarios fall into that RH Emergent group, where you can put them in on the nurse template and you don't have to wait for the specific RH day. Any questions related to that? And this SOP is also available on Moodle under the SOPs if you need to reshare. And yes, I'll be happy to send these questions and answers out with the presentation. All right, let's go to case study 3. Y'all chat in if you have any questions about that one. So here is one that you get a call, and an 18-year-old female needs to be seen because she's having some abdominal pain and some vaginal discharge. So let's see what you think about this one. Who are you gonna put her in with? In person, next day, same day, APRN on the next day, telemedicine, or RN to triage the patient? All right, let's share the results on this one. All right, so there's actually two answers on this that is acceptable. The first one would be to get that patient in with the STD nurse on the same day. That would be acceptable because when the STD nurse evaluates the patient, if there's any inkling at all of PID, then she would call the nurse practitioner and they would get them in for evaluation. The other answer that is correct is RN to either telephone triage, or if the patient walks in, the RN can go up into the waiting room and bring her back just to triage her, because it, like I said, it may require an urgent referral to ER or OBGYN, or someone who can take the time and make sure that they don't have PID or an ectopic pregnancy. So that's another thing the nurse would check for, is making sure the pregnancy test is negative. Okay, so great job, great job. We definitely just wouldn't want to have that patient wait because something could happen in the meantime of them waiting for an appointment. All right, case study 4. I think we've got a question. So that's a good question. I had one come up on my chat, and it says, if the RH nurse is completely full and you don't have any time slots available, what would you do? Well, I would say if it's specifically related to case 3, then they would need to be, the nurse would need to be notified, because this is not something not a patient we would want to turn away without having some type of evaluation. She would need to either call her real quick on the phone and send her to urgent care, or ER. We would not want to turn this patient away without somebody talking to her. Did I answer that question? Yes, definitely. This is a priority patient because she could have a tubal pregnancy or PID. So we don't want to turn anybody with abdominal pain away without having somewhere to go. Okay. Case study 4, a 40-year-old female calls the clinic to make an appointment to get treated. She said the DIS told her to call and get an appointment. Here we have an overwhelming response that is correct. It's going to be the same day. I'm going to pull that back up and show you. Make sure I'm sharing the right screen now, you guys. Okay, remember that any client who was referred to the public health unit by a STDIS meets that same day criteria, and you're going to put them in with the RHRN, or if you have it. If you don't have that template open, they can go on a normal nurse template as a RH emergent type visit. Another scenario, let's say that the nurse practitioner is there and both of the nurses are assisting that nurse practitioner. You can also put this patient on that nurse practitioner's schedule if you don't have a nurse's schedule to put them on. So absolutely, that was another question. Okay, last one is 32-year-old, this is the easiest one, wants to have her IUD removed. STD nurse, APRN next available day, or telemedicine? Yes, definitely. Of course, because this is something that we have to put our hands on to do, then we're going to schedule in person with APRN on the next available day. Absolutely. Great, great job. Any additional questions?